Let's clear something up at the start, because this topic sits in territory where clarity is essential. There is a meaningful difference between breath work as a wellness culture phenomenon, the retreats, the spiritual reframings, the social media influencers demonstrating extreme hyperventilation protocols, and breath work as a rigorously studied physiological intervention with measurable autonomic effects. These two things share a name and very little else, and conflating them is a genuine obstacle to clinical progress. The physiological science is solid. Breathing is the only autonomic function that is also under voluntary control. The diaphragm is innervated by the phrenic nerve, and its movement directly influences vagal tone, the activity of the vagus nerve, which is the primary driver of parasympathetic nervous system activation. This is not a theoretical model. It is anatomy. When you consciously slow and deepen your breathing, you are mechanically increasing vagal afferent signaling to the brainstem in a way that has measurable downstream effects on heart rate, blood pressure, cortisol, and inflammatory markers. Research from Stanford's Huberman Lab published in 2023 directly compared several breathing techniques against mindfulness meditation for reducing physiological stress markers and self-reported anxiety. The cyclic sighing protocol, a brief inhale followed by a longer exhale, repeated over 5 minutes, outperformed all other conditions, including mindfulness, in real-time anxiety reduction and next-day mood improvement. This is a head-to-head randomized comparison with a biological mechanism. It is not anecdote. Paced respiration at approximately 5.5 to 6 breaths per minute has been extensively studied in the context of heart rate variability optimization. HRV, the variation in time between heartbeats, is one of the most robust biomarkers of autonomic nervous system health and cardiovascular resilience. Resonance breathing, which synchronizes respiratory rhythm with baroreceptor feedback cycles in the vasculature, demonstrably increases HRV in a dose-dependent manner. Hypertension studies using paced breathing devices have shown blood pressure reductions comparable to some medications. The clinical adoption barriers are not scientific, they are sociological. Conservative clinicians encounter breathing exercises and associate them with yoga classes and wellness magazines, not with peer-reviewed mechanistic research. This association is unfair but not irrational. The wellness market has indeed appropriated these techniques and often misrepresented them. Overcoming that association requires not just good science, but deliberate clinical communication strategies that present breath work within a physiological and neurological framework, separating it explicitly from the cultural context that makes clinicians skeptical. If the evidence continues to develop, and there is every reason to expect that it will, controlled respiration protocols for anxiety, hypertension, PTSD, and inflammatory disease could become some of the most cost-effective interventions in medicine. They require no manufacturing, no prescription, no insurance authorization, just education and practice. The pathway from evidence to adoption is unusually clear. What it requires is institutional willingness to look past the cultural packaging.